All right, I think we'll go ahead and get started. Welcome. My name is Noelle Young. I'm a neonatologist at Duke University in the US. And on behalf of the Tiny Baby Collaborative, it's my pleasure to introduce you to today's speakers and our webinar, Empowering Parents After Birth at Less Than 24 Weeks Gestation. Our speakers today will be Karel O'Brien, who's a neonatologist and researcher at the University of Toronto in Canada, and Victoria Karlsson, a nurse and researcher at Uppsala University in Sweden. They're going to share a little about the approaches they have developed at their centers to empower parents after birth at less than 24 weeks. And following their presentations, we'll have a discussion led by our moderators. We have three neonatologists who are experts in this area. Dr. Eva Heine is from the University of Cologne in Germany, Mario Rudiger from University Hospital Dresden in Germany, and Agnes Lanier from Karolinska Institute in Sweden. And we're fortunate to also have two parents, Pär-Erik Nyquist and Kourtney Vier, who have generously offered to share their firsthand experiences as part of today's discussion. Sorry, okay. Just a few quick housekeeping notes before we get started. This webinar is being recorded and will be posted to our website, tinybabycollaborative.org. We welcome multidisciplinary attendance at the webinar, including families. And if you have questions that come up during the webinar, please use the Q&A button in Zoom to post them. And our moderators will do their best to address as many as they can, either by typing a response or in the discussion portion at the end. The Tiny Baby Collaborative will be hosting an in-person meeting at PAS 2025. It's going to be held Friday, April 25th from 7 to 10 a.m. If you'd like to attend, you need to RSVP when registering for PAS. We'd love to have you there, but if you RSVP, please make sure that you can attend as space is limited. All right, so in attendance today, we have a multidisciplinary group of neonatologists, nurses, nurse practitioners, fellows, and others from over 30 countries. On the registration forms, we asked the earliest postnatal age for which skin-to-skin is provided in your hospital at less than 24 weeks gestation. And you can see here that we had a variety of responses, but the most common being between days 2 to 4 and days 5 to 7. Less than 10% responded that skin-to-skin care is provided in the delivery room at this gestational age. We also asked about the number of babies housed per room in your NICU, and you can see just over 40% responded that you have single-family rooms, whereas the next most common responses were 5 to 8 infants or 2 to 4 infants per room. 38% responded that parents can room in with their infant in the first postnatal month. And this was strongly correlated with the NICU design being, with rooming in most common among respondents who answered that they have single family rooms in their NICUs. All right, so sorry. Stop sharing. With that, I will go ahead and turn it over to Dr. O'Brien to begin her presentation.
I hope you can see my presentation. Thank you. So good afternoon. I think it is afternoon, everybody. Thank you to the Tiny Baby Collaborative for inviting me to speak today and really for asking us to discuss this important topic. As depicted here, I see parent engagement as a little plant. It really has to be nurtured from birth, and that really includes the resuscitation room. I'm sure Victoria will give us lots of ideas of what to do to improve this. But when I first was asked to talk about this, I wanted to understand what was empower, because sometimes empower is an overused word. But by empower, as defined as the authority or power is given to someone to do something. So in the context of the NICU, empowering parents after birth, particularly with these extremely preterm infants, has come to mean many different things. Empowering parents to be engaged in the care of their infant, empowering parents to advocate for their infant and for themselves, and empowering parents to be involved in setting the research agenda and defining the important outcomes for their infant and for themselves. So most of our talk today is going to be talking about empowering parents to be engaged in the care of their infant, but I do want us to think about the other pieces of empowering. And so let's talk about why it might be important for parents of extremely born infants to be actually involved, to be engaged in the care of their infant within the NICU. I want to take a moment to reflect on what we know about preterm infants' outcomes and how parent engagement in care might actually alter these outcomes. We know that extremely preterm infants are at high risk of behavioral problems, anxiety, depression, attention deficits, without formal diagnosis of neurodevelopmental impairment or brain injury as seen by head ultrasound findings. We also know that these infants who have these internalizing disorders, they're associated with learning disabilities and academic and social difficulties at school age. And we know that these problems can actually go on and affect the adults, not just the children in school. Harlow's experiments from the 1950s taught us that the contact comfort of a mother has an important impact on the development and behavior of an infant. Yet when we built our first special care nurseries, the first thing we did was separate the mother from the infant. It's not a surprise for anybody in this audience, but just like Harlow showed us, we all know that early experience shapes the brain of an infant. The preterm infant's brain is still during development and is therefore very vulnerable. The early experience affects the volume of the brain, the microstructure, and the connectivity, even in the absence of brain injury. This slide is a picture of the brain of a preterm infant at term. Both slide B is the brain of an infant who was born preterm, and slide C is the brain of an infant born at term. And you can see how the brain volume is decreased in the preterm infant, and the microstructure of the brain is very different than in the term infant. The medical and social and environmental factors are associated with abnormalities in brain maturation that have regional specificity. So, for example, we know that pain has a direct effect on the development of white matter of the brain. Infection appears to have an effect on thalamic development, and recurrent stressful events actually impact the hypothalamic pituitary axis. And these effects can continue even post-term and on to childhood. Parents have a major role in shaping infant development. We all know about the importance of skin-to-skin care. Parent engagement in pain management protects the brain from white matter injury. Attuned parents can provide developmentally appropriate stimulation, and parents actually are the people who regulate infant-toddler behavior way beyond the NICU. There is also evidence that suggests a clear dose response between parental presence holding with better quality of motor patterns at term equivalent age and less arousal and excitability post-discharge. Again, for this audience, I probably do not need to reiterate the benefits of human milk feeds, but this is definitely improved by parental engagement in care, and parents need to be supported in this from birth. A good example from Betty Vieer's research work is that exposure to maternal talk is a significant predictor of infant vocalizations. And the more parent talk that a baby is exposed to, the greater the 7 and 18-month-old language scores. Also, what also important is that the parent mental health actually has an impact on the child development post-discharge. Parental stress and depression negatively impacts infant and child development. Maternal behavior can actually moderate the adverse effect of neonatal stress if mothers have low stress. From my work and those of others, we now know that parental presence in the NICU decreases parental stress and anxiety at discharge and increases parent-infant attachment and improves parent-infant regulation. So for this group that we're out talking about today, the infants who are born less than 24 weeks, I think there are many special considerations about this population that we need to take into account when we're talking about parent engagement. The first, of course, is going to be the longer course in hospitals. So these families are looking to a much longer course in hospital prior to being discharged home. And that can both be good and be bad for those parents. Also, it's important to recognize that the babies themselves need complex care, particularly in the first few days following admission. That we also know that these infants, however, may have more complex needs post-discharge, and it's really important that we bring the parents along on that journey so that they can take care of the baby post-discharge home. And of course, as was brought up by one of our people when we were developing this talk, the infants may be at increased risk of morbidity and mortality, and that needs to be taken into account when you start getting parents engaged earlier in their care. Parent engagement in care, I would argue, does not happen in a vacuum. It has to be part of a model of parent-partner care. There are many different models of parent-partner care, as illustrated in this slide. FICARE, Family Integrated Care, is the model that I'm most familiar with, and that was developed in the Canadian context. But you can see there are other models as mentioned here. A model of parent-partner care is what is different than what we call parent-delivered interventions or parent support interventions. Family integrated care includes components of all of those, parent-delivered interventions, parent support interventions, but it truly puts the parent at the center of our system of care, looking at what we need to do to support families so they can be engaged in care. And I think this is really important with the more extremely preterm infants. We want to support families to be parents when they're actually in the NICU. The model of family integrated care, and I'm not going to spend much time on these slides, because the talk is not about family integrated care, it's about family engagement in the care of these extremely preterm infants. But just to show you here, the model of family integrated care was built on the principles of family-centered care and involved these 4 pillars: parent education and support, staff education and support, environmental supports, and psychosocial supports. What's stated here is applicable to all parents, regardless of the infant's gestational age. Parents need to be encouraged to be parents in NICU. The ideal environment for an infant is in the arms of their parents, and parents need to be recognized as collaborators in care, particularly as we're going to need their collaboration as the course in hospital is prolonged and a more complicated discharge. And parents really have an important role in contributing to decision-making as parents, not as medical care providers. What do we mean by parent education? We mean providing experiences and knowledge to parents that enhance their partnership between staff and parents. And that's key to parent engagement in care. This research paper describing the experience of women of color interacting with healthcare providers highlights for us how important sharing information with parents is, and not just for the parents to seek out the information. Information is power, and we hold that power in that relationship with parents. So if we want to actually engage parents in the care of their infant and collaborate in decision-making, we need to provide that information to them in a way that respects their needs and their ability to take in that information. And they need to be empowered consistently. To be clear, parents are still parents and should not be asked to make medical decisions when they do not have the knowledge to make them. A critical piece of implementing family engagement in care is to provide all the healthcare staff the knowledge and support that they need to be able to grow parents as part of the team. And that can be using communication tools, skills checklists, baby step to discharge tool. But what's also important is to invite parents to collaborate in education of staff and orientation of new staff to the unit so that our staff learn how to communicate with parents. Some units have reorientated their staff hiring process to actually include parent advisors. It is also vitally important that the role of bedside nurses, especially, is seen as critical to parent engagement in care, and that administration and leadership make a commitment to parent engagement in care with expectations re staff behaviors. Staff need to be accountable for their behaviors as much as they are for infection control. So what do staff need to support parent engagement care? One of the first things we've learned is that staff need language translation, particularly in those first few days after delivery. Staff need tools, whether it be, they need language translation tools at the bedside, whether that be actually in-person language translation or something available online. They also need communication tools that work between staff and families. You need to address staffing and workflow issues so that actually staff can support parent engagement, particularly with these critically ill infants. You need to give staff recognition for the work and celebrate the actual things when they actually make things happen at the bedside. And we need to provide ongoing education and support for staff around parent engagement and care. Parents have told us this is what they need from the bedside nurse. They want the bedside nurse to listen to their stories, to understand where they've come from. They need to feel like they're being coached at the bedside. They need to be invited to engage, to teach, and the staff actually are the people who model for families how they can engage in the care of their infant. And also that the families say that they want the staff to understand what parents need in this complicated setting and provide that education to them at the bedside. Just some tools that families have told us. They want staff to actually give them a voice to speak up, understand those small gestures of empowerment, even things like showing parents how to do the hand hug when they actually meet the baby for the first time, showing them how to change the diaper and how important that is to them, and use those sort of strategies for family engagement. Of course, in family integrated care, we've also talked about the need for psychosocial supports for families, and that can be group or one-on-one support. And definitely we know the importance of peer support for supporting families in their NICUs. And finally, environmental supports. And I think this one is self-explanatory, but as you saw in the other slides, unless you have the space for families to be there, not necessarily single rooms, but unless you actually provide supports for family to be present, it is very difficult for those families to be present in their NICU. On the other hand, providing single family rooms without a culture that supports family presence is also not productive. Now, parents grow into their role as care providers at different paces. So one of the things we've been told by families is that they do not want to be left on the bottom step. They need to be told that they have a role in their baby's care from admission, from first seeing that baby in the resuscitation room, from that first time that they actually see the baby in the NICU. But they also do not want to be forced to do things before they're ready to do them. So it's a combination. We have to teach our staff how important it is to engage families and provide the support to families to be engaged as they can over time. This is similar to our journey with families on rounds, that families, of course, when they're in family integrated care, when families, first of all, are engaged around, they just listen to rounds, but they grow in their role over time. It's not something that happens instantaneously on admission to the unit. One of the things families have done for us is identify what they call critical beginnings after birth. And that first critical beginning, and we're going to hear about today from Victoria, is actually that first time they see the baby in the NICU and how they're encouraged to engage in care from that time. The next critical time is the first time they actually come into the unit and actually see their baby there, or if in the ideal situation where they actually have a space in the unit and are actually there with their baby during the day. The next thing is sort of understanding the NICU journey, going from admission to sort of projecting for discharge and having an idea of what that's going to look like and what sort of supports they are going to need over the time to manage their family, their time, how they're going to be able to actually engage in the care over the time in hospital. And of course, the biggest part then, the next critical period, is preparing for discharge. Importantly, each family in the NICU has a unique journey, and not all will be able to be or be willing to be present with their baby for long periods of time. So we need to collaborate and make this happen. But one of the first things is getting those parents off that bottom step, making them surely realize that they are important to their baby's care and that they are important to their protecting that little brain's development over time. Facilitating parent-infant attachment is so important that even if the parents can only be present for a short time, it is really important to make that hour count. And that needs to be our mantra in the NICU. Parents are all individual and they need help adapting to their new role in the NICU. Sometimes these are first-time parents, so they need to adapt not only to the NICU, but also to being parents for the first time and their whole world being turned upside down. We need to be able to we need to really, I think, to improve parent engagement in care, we need to improve our communication with families. Some parents may not be able to be ready, so it's important to ask them, are you ready to? But at the same time, encourage them to. So it's that fine line between parents being forced and being encouraged. We need to decrease nursing practice variation with parents. That's really a problem for families where they're allowed to do things with one nurse and not allowed to do things with another. We need to personalize parents' care if parents need greater support. and enhance the interaction, I think, with peers or with veteran parents to support them in this journey. So the engagement of parents in the care of preterm infants, as I had on one of my opening slides, is not just about the engagement in the care in the NICU. It actually continues way beyond discharge and actually can improve our care of these infants long-term by involving parents in both research and in developing the important outcomes that we need to, or telling us what are the important outcomes, the outcomes that are important to families post-discharge. Take-home points of my talk today is that engagement of parents in the care of all infants, regardless of station age, is really important and needs to be seen as an essential part of the care that we deliver to all infants in our NICU. It will not happen, though, without support for both staff and parents. At its best, it will be part of our NICU culture, like the people from Uppsala will talk about, and like Victoria present, we will find ways to make it happen. Thank you. I'm going to hand it over to Victoria.
Thank you, Karel. You can see that okay?
Perfect.
Thank you. Thank you to the Tiny Baby Collaboration for inviting me to this talking about this important topic. My intentions today is to share some of the evidence that we have about empowering parents to infants starting their life in the NICU, and also sharing our perspective from Sweden, Uppsala, with examples of how you could possibly include families in their infants' care early in life. And I'm going to start with sharing some quotes from families that have been interviewed in research, trying to figure out how we can support families best. This is from a recent Swedish publication. A mother saying that I felt that it wasn't even a baby at first. Well, you sit there and hold her because that's my role. That's what someone's told me to do. And this is also from the same publication, so it's from a Swedish context. I could not live up to the expectations. You're supposed to be happy that those babies were born. Sit there and watch them all day and night. I couldn't cope with it. I did not want to. And reading this, we all of us are aware of the important task that we have to support parents to become parents and help them on this journey and do what we can. This is from a center in Canada where they introduced the family integrated care, and they wanted to ask the parents to see what their experience was. And all parents described that family integrated care benefited them, empowered them, and helped them feel like parents and become a family. So this is a mother saying, I really enjoy doing these things. And by these things, she meant taking care of her baby. It made me feel like a real mother at first, and then at some point, like a good mother. This is still from the same center in Canada. At first, I felt the nurses did all the things I should have done, that I wasn't a mom. And that is, I'm sure that it makes us all sad to hear that someone experienced that we take their babies away from them. So inviting families to be close to their infants right from the start is of greatest importance. And in their job at this center in Canada to evaluate that they started with family integrated care, they asked the parents, and they came up with these 3 main themes that families said that their family integrated care enabled them to be and feel like a family and feel like real parents. They have a desire to feel like and be good parents. And being a part of their infant's care strengthened and empowered them. It even at sometimes repaired the trauma of being a parent to a preterm infant. So it seems like families and their infants have everything to gain on us letting them in the care and allowing them to care for their own infants. And this is also from this Swedish publication, parents describing like turning points during the NICU stay, points that they clearly remembered, like a growing feeling of being a parent. And these moments were moments of interactions with their baby, like emotional moments. And here's such a turning point described of a mother. She said that when the lid of the closed incubator were raised, she felt that she got so much more access, and she were able to smell, breathe on her baby, and she could kiss her. So this about coming close to your infant is and be able to smell them is a well-known important thing for a cue for recognition and bonding to the infant, that mothers recognize the smell of their own baby is well described and well knowledge, and it serves to trigger the positive response to protect, nurture, and care for the infant. So the infant's sweet smell is a part of the infant cuteness that's gonna want us to care for him. So to allow the parents to get close to their infants, to be able to kiss them and smell them, is an important early intervention in supporting them being parents. So according to our routines, we always raise the lid of the incubator when we perform care like diaper change, and we do that from the first day of the infant's life. So on the picture to the left, there is this baby girl born at 23 weeks, and she is less than 24 hours. And here is the incubator is opened, and the parents have possibility to kiss her and smell her. And these moments usually get very emotional. And this particular mother, she said the first thing she said when she got to get close to her was that she said, "It's a baby, it's my baby," and it could be the first moment of awareness and feeling that that's their baby. The picture to the right, the girl is on the second week of life, and the parents are getting ready for a diaper change. And the ability to stay overnight, that is an important part of the unlimited access to the infant. And as parents are asked, they describe the possibility to stay overnight is one of the most important factors promoting the infant-parent closeness and feeling involved in the care. our unit is 20 years old. It was not built for rooming in parents. So we have 4 families in the same room, and along the journey we have kind of created space to fit an adult bed at each infant's care space. So the picture to the left, it's set up to show, just to show how the care space can look. So we have the incubator and always an adult bed as well. So the picture to the right shows a mother. She's not holding her infant skin to skin at that picture, but they are sleeping next to each other. So that has been our solution to offer the parents to be there 24/7. And I know when you read what parents say, and when we evaluate the effect of family integrated care, families can express that they do not feel confident to speak up for their infants during rounds. And our experience is that when parents stay 24/7, they sleep bedside with their infant or with their infant, it seems like they are much more involved even in the rounds. Once the rounds get there in the morning, they have been with their infant all night, they know how the night has been, they know what's going on. So it seems like an effect of sleeping with them also get them much more involved during the daytime at rounds, for instance. So of all the things that we can do to involve the parents, the 2 most studied and powerful interventions that also can only be provided by the parents, that is mom's breast milk or breastfeeding and skin-to-skin care. And as time is limited today, the only thing I'm going to say about breast milk is that giving the parents possibility to express breast milk bedside is one way of supporting them to be able to stay with their infant and not have to leave them. And now on to skin-to-skin care. Skin-to-skin care is known to have a great benefit for the infant, but besides that, it's also known to decrease parental stress, anxiety, and support them in the process of becoming parents. And for the infants born before less than 24 weeks gestational age, we don't know as much as we do for the more mature infants. For more mature infants, there is solid evidence that it increased survival, improved outcome for the infants, even in settings with unlimited and very good resources, not just in settings with limited resources. And what do we need to be aware of when we want to care for these infants skin to skin early in life? That is their great risk of hypothermia, but we have evidence for that infants, even the most immature infants, do keep a normothermia during skin to skin early in life. But the transfer between incubator and the parents is known to cause cold stress and a great risk for hypothermia. So the transfer between incubator and parent has to be done very carefully with the aim to reduce cold stress. And whether there is an increased risk of intraventricular hemorrhage or sepsis, we might not have that solid evidence for it, or not, but a recent publication from Sweden looking at data from the quality register, there is no increased risk for IVH or sepsis. And here I'm gonna just give you an example of how the transfer can look like between incubator and parent. And this is a way that we have worked out to make the transfer as less stressful as possible and decrease the risk for cold stress. So the infant is placed in a nest covered with a wool blanket, and there is one person responsible of securing the endotracheal tube, and one is holding the infant. And as you see, the mother is placed in the bed. And I'm going to show you a short film clip, what it can look like. So they lift the infant out, the infant placed in the nest. The incubator is moved out of the way, and the parent's bed replaces the incubator. And the infant is carefully put down on the parent's chest. And the infant can be covered with the blankets during the whole transfer, and it won't take long to move the infant from the incubator to the parent's warm chest. So that's a routine that we have worked out just to reduce the time that the infant is exposed to the surrounding cold air. And the nesting during skin to skin, when you care for these infants early in life, this is our way of doing it. And this is in an effort to create like a microclimate around the infant. We have a rolled up blanket around the infant to support it and to create this smaller space for a microclimate. Cover the infant with wool blankets and with an extra, like a thicker blanket on top of that, and close the parent's shirt around. And this way the infant is in a supported position, and the parents can also rest while they have their infants on the chest. So here is an example of the routine we have chosen to initiate skin-to-skin care and for duration of skin-to-skin care. And we like to think that with support from research of and knowledge of the transepidermal water loss for these extremely preterm infants, we have chosen to initiate skin-to-skin care at the end of the first week. During second week of life, we still do skin-to-skin intermittent, and third week of life, we have unrestricted skin-to-skin care. And I'm just briefly going to walk you through this figure. And as you can see, there is gestational age on this axis and postnatal age on this axis. And here is the transepidermal water loss. And you can see it's just a 26-week gestational age, but you know that the infants we talk about today, born before 24 weeks, have an even greater transepidermal water loss. And at the start of life, during the first week of life, there is an extremely large difference between the full-term infant and the preterm infant. but there is a dramatically change on the infant's skin and the amount of water they lose already during the first week. So by the second, third, and fourth week, they are almost lose the same amount of water as the full-term infant. So as the transepidermal water loss gradually decrease, we also increase the amount of skin-to-skin care we allow. And as parents express when asked about involved in the care of their infants, they want to have a role and they want to be invited in the care of their infant. And with the experience we do have from Uppsala, Sweden, we want you to encourage you to trust the parent's ability. On this picture, there is a father to an extremely preterm infant. He is controlling the feeding tube prior to start feeding his infant. So support families and involve them in care early. We think we have been successful with this raising the lid of the incubator intermittently just to offer closeness. And I want to, this is a family, the boy are born at 22 weeks and this is the third week of life. They are just about to finish the diaper change. And both parents take a turn checking that the diaper isn't too tight. They give him a kiss and they hold him. And of course, the first couple of diaper changes are not perfect, but they are always gentle and with loving hands. And they learn fast. So after just a couple of weeks, they manage all this primary care on their own. Here's also a father of a girl born at 23 weeks. She is less than 24 hours on this picture, and he's changing her diaper with support of staff. And the possibility for siblings to be at the NICU is one way to support the families to have access to their infants 24/7 when they can keep their family together. And here on this picture, there is an older sister sitting at the end of the bed, watching a movie and having a snack. Here's on the picture to the left, there's siblings. The baby boy is intubated and on ventilator, and his older sister is also taking a nap. And our like homemade routine in Uppsala is that siblings, preschool children have to be home from preschool for 5 days before they're allowed to be in the NICU, and then they are allowed in the NICU unrestricted. So I want to end with this picture of this baby girl interacting with her mother. And we want to encourage you and share our experience to involve parents in care early or immediately. And start skin to skin early and trust parents' ability. They do it with more loving hands than what we ever can do, and we cannot do the kissing and that part. That there's things that only parents can do. And having another bed at infant's bed space so they can be side by side 24/7 is has been a successful for us to have parents close by 24/7. Thank you.
So thank you very much, Victoria and Karen. It was a very excellent introduction to this very important topic. And I think that about 400 participants are sign of being big in having big interest in this topic. And thank you very much for Tiny Baby Collaborative to having this topic. And I would like to ask a first question because I was surprised to see that about only 10% of the participants said that they have skin-to-skin contact in the delivery room. It's a very small number, and I think in my institute, it's a very important aspect that we have skin-to-skin contact in these tiny babies even. And so I would like to ask first, Kourtney, from a point of view from parents, how important it is for you, and thereafter would like to ask Karel again, because I think there's one very common topic in the questions, and that's a balance between risk and benefit. And so, Karel, I would like to ask you afterwards, what do you think? What is a risk and what is a benefit? But first, Kourtney.
Yes, my experience, I was able to give skin to skin just with my hands to my son, who was born at 23 weeks. And shortly after he was delivered, the doctors did like kind of bring him over to the bedside while they were waiting for the nurses and the NICU team to be ready, and then kind of took him off, but allowed me to have that first kind of moment with him. And then once he was intubated, they let us go into the room, and we were able to provide just skin to skin with hands. And because of my son's situation, he had necrotizing enterocolitis and several infections during his first 2 months. I didn't actually get to hold him until he was 65 days old. But throughout the whole experience, I felt empowered by the nurses and the doctors to provide skin to skin care as much as I could by hands, me and my husband. And I think, Mario, you bring up a really good point of trying to balance the risk, but also the benefit. And I felt extremely supported by the team telling me, especially, during the first week or first few days, there's such a high risk for brain bleeds. So we need to be as careful as possible when we're changing diapers or rotating your son. But at the same time, also giving me the information, telling me how important it is for my son to hear my voice and to feel my touch, and also my husband's. And so I think you're right in saying there's a balance between providing the risk, but also feeling empowered to say, yeah, we want to be careful when we lift and do the diaper change, do the best that you can. But at the same time, the benefit to you touching is so important as well.
So I think, Mario, this is I think Kourtney really captures that question about who controls the information. So Kourtney, it sounds like you were limited to doing what we call a hand hug. So you did hand hugs. And that's in many institutions, that's what families of extremely preterm infants are only allowed to do, and not to do skin to skin. I think that's why it was really important that Victoria present her information here today, particularly to a North American audience. I think one of the things that was really, really unfortunate, in fact, was the work that came from Germany about the IVH bundle. And somehow that got ingrained, that somehow got a more power in particularly in North America than skin to skin did, with very little evidence. So I feel that really needs to be challenged. And Kourtney, so the question about keeping the baby, not moving the baby, keeping them in a single position, not moving them even, sort of was part of the way that has actually been seen as a barrier to parents providing skin to skin. I think Victoria presented that lovely moving in the nest, where you can keep the baby really in a neutral position and still move them. But really, the IVH bundle is portrayed by most North American institutions as a reason not to provide skin to skin in the first 3 days. So it really is concerning.
I was not aware that the impact is so big of this bundle, because almost nobody's using it in Germany anymore. And I would like to ask Eva, because they have a big experience on doing skin to skin in the delivery room, and there are very good data from Cologne. Maybe Eva, you can just present some of your experience on this one.
Yes, sure. Thank you very much. Yeah, we do skin to skin contact even in the delivery room. you do have to have some requirements to do this, like the RDS has to be treated, like we do perform NISA, and the infants are on CPAP. We do administer caffeine before that. You do have to have a temperature management. And then, like in this whole bundle, the infant is more or less like 45 minutes old, and then mostly the mother is also ready from the C-section, and then we perform the skin-to-skin contact in the delivery room. And then we position the baby in the lateral position, in comfort positioning. It's a little bit like I think Victoria showed us. And we also put like polyurethane foil on it and preheated blanket, so to keep the temperature stable. And we also do this in 22 and 23 weekers. And we have published data of 25 to 32 weekers, and we couldn't see any adverse events. And also in my experience, we have never had adverse events, and the temperature was even better than in the control group with only visual contact and no skin-to-skin contact in the delivery room.
I have a very similar experience in our unit, and one reason for introducing the skin-to-skin in delivery room was to have a period where the baby is very quiet. You do not do anything on the baby. You have 1 hour of baby is just bonding to the mother, and it's a very quiet period. And then it comes to the NICU, and then there is some stress again. And but maybe to Pär-Erik. So what is your experience about the very, very first minutes in the delivery room? So what is important for you from father's side of you? Sorry.
Well, in the delivery room, we did not have any skin-to-skin care because our daughter was delivered through an emergency C-section, and my wife was unconscious at the time. So she experienced significantly less contact with our daughter for, I would say, even the first 3 days compared to me. So our experience from the delivery room in particular did not involve our child technically at all. It was not until my daughter arrived to the resuscitation room that I first laid my eyes on her. However, we had unfeathered access for at least hand skin to skin for the first 3 days. And we had the first time that I had her up in my arms was 3 days after birth. I've recently checked my pictures, and I took a picture 72 hours after birth. It's the first one I have of her.
It must be an amazing moment to have the baby on your skin for the first time. I would like to shift from skin to skin, and Karel, you have the title of your talk was Empowerment of Parents, but mainly it was about involvement and supporting parents. You think it's sufficient to involve and support the parents, or is there empowerment? Is it even more than just involvement?
Great question. I think empowerment is more than involvement. And I think, I think this was not our title. This was a title that the Tiny Baby Collaborative brought to us. But so that's why I sort of had to look up to see what it was. Empowerment, I think what they wanted us, I think what most people in the audience want to hear about is actually engagement in care, empowering parents to be engaged in care. But I would argue that empowerment that's just one piece of the empowerment, and that's critically important. And as we heard, it's sort of and really those important, those magical moments for family and creating that connection of parents and children is critical and really is important, not just in the NICU but beyond. But the empowerment of parents, that next piece of really growing parents as partners in care, so that they can partner not just in hospital, but particularly and post-discharge, but so that their own stress is decreased, that they truly feel that they're engaged, that they are parents, is huge for that baby post-discharge. It's huge for that family post-discharge. That, you know, even with the most extreme preterm infant, you know, even the 22-weeker, they're only spending another, you know, 20 weeks in our NICUs. But the next, you know, 12 years of their life, those parents have those really strong memories of those months in hospital, and it can really disrupt their ability to be able to manage their child, the child's behavior, to regulate themselves, that the mental health effects on the parents for long term. I really think empowerment of parents is more than just engagement in care, and it's really neat, Mario, now how parents are beginning to set our agenda. What are the important outcomes that we should be looking at for these kids? Is it, you know, whether they've had an IVH or not, or whether it's actually whether they're happy, whether they're able to go to school and engage with and have lots of friends. You know, that are those might be the most important outcomes that we need to look at long term. So I think it's a lot more.
So I think the empowerment does also require team change. So you have to change the idea of the team, what the team is responsible for. Would like to ask Agnes. Karel was already talking about you have to train the nurses to become a trainer, and Agnes and Victoria, for instance. So what is your opinion concerning the requirement, how you have to change the team or the attitude of the team towards the parents?
Yeah, I had a similar question actually, because I really enjoyed the talk by Karel, how she explained the different phases of during the rounds family centered, and I have a question actually, whether there's a conflict between involving the parents, maybe even letting them lead the rounds and being able to transfer information between the members of medical staff. Is that ever a conflict, according to your experience?
So I think, you know, we have had more conflict with families when information was not shared and they felt they couldn't listen, that people were not listening to their opinion. So are there ever any conflicts where parents try to sort of come up with try to engage in a medical decision that's different than what the medical team? Of course, that's part of negotiation. It's part of care in the community. If you're a pediatrician in the community or you're an adult doctor taking care of a patient. And I think we don't have as a hierarchical a sort of that communication between physicians and families is not perhaps as hierarchical in different cultures as it is in others. But in fact, my motto has always been that a family in distress is often a family who need more information and want a sense of control and don't feel that people are listening to them, rather than the opposite. So we've had, I think, less families who are in conflict with our medical team once they actually know how decisions are being made and feel that you're at least listening to their opinion, and explain to them what they can and cannot contribute. So I think I think it is different in different cultures, and I acknowledge that in certain cultures that's been more problematic than others. I spoke to a team in China, and what they didn't want the parents to know there was any doubt about their medical decision making, that there were any grays. Everything had to be black and white. So they didn't want to demonstrate any gray in their decision making. But I think, you know, I actually think it decreases the strife between parents and medical care providers, but you need to be open about that.
Yes, I was thinking of how Victoria shared how the parents become more and more confident when they spend time with their children, they sleep together and so forth. And then what about the junior nurse, for example? I mean, we're quite used to, I think, telling the parents how their child is, but how confident are we in being wrong or thinking together with them, sort of exploring the situation together with the families? I think that's something that you need to learn. It doesn't come from nursing or medical school. It's something you need to train your staff in if you want to work family centered during the rounds. I don't know what you think.
No, I totally agree. And I think the close collaboration care group in Turku, I mean, that's basically what they've made a course out of, trying to teach nurses to be able to do that collaborative care. I mean, in Turku, they have all of the other pieces of family-centered care in place, but even though they had everything else in place, this communication piece still needs extra support, or they believe that's a key that needs extra support. So I think it does, and whether it needs the close collaboration in care education or whether it can be done another way, I'm not sure, but I think it has to be highlighted that communication is a big piece of this for all families. You're in hospital for 3 months. It is a long time. It's a short time in a child's life. It's a long time for those poor parents and negotiating that role at the bedside. Yeah.
I want to mention one thing about the rounds. There is one huge difference between Agnes, Pär-Eriks, and my experience in North America. It's the amount of people attending the rounds. In Sweden, we have a doctor, a nurse, and an assistant nurse. That's it. So correct me if I'm wrong, Pär-Erik, when during the rounds, there is no unfamiliar faces. There is the 3 people that are nearby and close by the family all day. So medical rounds, it's not like, I don't think it's a big deal. It's just a particular time of the day when we are all together at the same time. And I think you always met only people that you are familiar with. Am I right or wrong?
Yeah, that is absolutely true. I was familiar with everybody, and I spent so much time with everyone that it felt like talking to coworkers, or maybe even distant relatives, part of the family. I also never quite understood the big deal of why even doing the rounds, because whenever we needed to talk about something, we did so immediately. We never waited until there were any rounds. Maybe during the night you understood that there were less staff on hand, but otherwise they seemed almost bureaucratic to do it that way.
So I think when we read the work that's done, for instance, the one publication I had from Canada that Vier and colleagues did, parents expressed that they felt uncomfortable to talk during rounds, and I can see how that is, because there is a lot of people there that they might not be familiar with. It's a big group of people, so it's a different situation. So I think that's for us. It's a benefit that we're not that many different professions. It's just a few of us.
So there are a few comments in the discussion which refer to the gestational age, because we are actually talking about very preterm babies, very tiny babies. So Victoria, is there any real difference between a 24 or 23 weeker and a 27 weeker regarding the involvement of parents in your unit?
I like to say no, that there is no difference. The difference is that I said that we do withhold skin-to-skin care for a few days, but regarding the amount of time the parents spend side by side with their infant is the same, and for the infants born before 24 weeks, we have kind of centralized the care within our center. So that's in a particular room where we make sure there are as few staff as possible, and no one that doesn't really need to be there are not allowed to go there. So limit the amount of people. We might manage to amount of staff more for the infants born before 24 weeks, but regarding parental involvement, I would say it's the same.
So we already talked about the delivery room and the time on the unit. What about going home Kourtney, what was your experience? That's a very important step of your career in the NICU. Sometimes you have to go home. So did you feel very well prepared, or is there anything one should improve in this one?
Yeah, when I was thinking about what did the nurses and doctors do to help us prepare, there's a few things. So the first thing that we did was they made sure that we stayed the night with my son Zeke before we left. And so there was a few nights, unfortunately in the NICU that I was at, there wasn't a bedside option for us. And so the only times that we would ever stay the night was if something was not going well for Zeke, and so we would just sleep in chairs. But they did give us an option to bring a cot in, and so there was 2 nights that we stayed before discharge, so that I made sure I understood all of the nighttime meds, and making sure that we felt empowered, because we not only had a baby in the NICU, but we had a 2-year-old at home as well, and so making sure we were prepared. The second thing that we did was we met with a post-discharge, with a nurse about post-discharge. And so she went through all the medications, and almost in a way that this sounds a little impersonal, but it was almost like a quiz, like, let's talk through Zeke's day. Let's talk through his medications. Do you have any questions about them? And so she spent probably 30 minutes with us, just going through all of his meds. And the staff had gotten to know me and my husband well, because we never missed a day. We were there from 7:30 in the morning until 9 p.m. at night, trading off between my husband and I. And so they knew our level of comfort. And so that also felt good, that we were talking with people who knew us personally well. And then the third thing I would say was we had, after we left the NICU, we had follow-up with our NICU team up until my son was 2 years old. And this was a game changer for us, because we were able to go in I think it was like every 3 months. We might have gone in even 6 weeks after we had left the NICU, and we were able to meet with the same team that cared for him. And so I knew that if I had questions along the way, I was going to see them in the next month, or I was going to see them in the next 2 months. And so I felt so thankful that when we left the NICU, I didn't have to meet a new pediatrician right away, or a new doctor who would tell me, here's what we're doing with your son. They knew my son from day one all the way to the end. And they also gave me the ability to pick the neonatologist and fellow who we met with. And so we were able to pick 2 doctors who we felt very comfortable with, and we met with them all the way up until 2 years old. And so even in the NICU, that gave me confidence to know that I wasn't losing my support team just because I was going home.
There was another question in the chat about medical terminology, maybe for Pär-Erik. So what was it difficult, or even for Kourtney, was it difficult initially to understand the neonatologist, because we are using quite a lot of medical terms?
I think if I answer that first, maybe this is a better question for Kourtney, because I did my bachelor in biomedicine and my master's in drug development. So I understood everything immediately, and what I didn't understand, I had the skills to understand. This was somewhat detrimental, as in I would then also understand what's going on with all of the children that are also in the same room when they are experiencing difficult times, which my wife was oblivious to, which did put some additional pressure on me. But it was never hard to understand what was going on with our daughter.
I will say, I know we talked about a little bit of the maybe the pressure that parents feel during rounds, and that might make parents feel uncomfortable. I'm different in some of the feedback that you guys received. I loved rounds. They were intimidating at first, but I really felt empowered to say, this is the team who's going to care for your son. So I was learning how to be a mom to a baby who was in an isolette, and it felt like, okay, I don't have to do this alone. I can hear everything and learn. And so I have a bachelor's degree in human resources, so nothing even close to medical. So I did not know what they were talking about. But for me, I just, my personality, I was able to ask questions when I needed to. However, some of the best nurses that we were with, after the rounds would go on, they would say, like, Kourtney and Riley, do you have any questions? That's my husband. And we would ask questions, but then sometimes the nurses, once we get back to the room, because rounds took place outside of the room, the nurse would say, hey, do you want to run through everything that you just heard, or do you have any questions? And so even though I loved rounds, I thought it was really empowering and cool to watch people care so well for my son. I also appreciated that bedside nurse who was able to say, were there some things, let's run through this. What did you hear? And so sometimes even in rounds, I would say, okay, this is what I heard today of what we're going to do. You guys are going to do, X, Y, Z, all of these things. Did I hear that correctly? And so making sure that not only did I feel empowered to talk during rounds, but also that our bedside nurse was able to answer questions, and the willingness for the doctors to say, hey, if you didn't understand something, we're happy to come back into the room. So I love family-centered rounds. I encourage everyone to try it.
Maybe
So
another question from the chat. Sorry, Mario, but I was reading the question in the chat about the balance between being supportive and not being overwhelming. And I'm not talking there. I think the question is not about medical information, but more about the expectations. How much to be bedside? I mean, are you allowed to leave the unit at all? Do you need to be there 24/7? What about this balance between always being there and being able to have time outside the NICU every once in a while? What's your experience, maybe Kourtney and Pär-Erik? Did it ever feel overwhelming, the family involvement for you?
Of course it did. No one expects to my son was in the NICU for 182 days, and I never expected to be, especially mostly in a dark room with my son for so long. However, the nurses and the rest of the support team, like child life specialists, social workers, chaplains, doctors, a whole team of people who cared well for us to say, hey, you two need to go out and get some fresh air, or no pressure. Like we've got Zeke, we're going to take care of him. And even the support that we felt, like I mentioned, we had a 2-year-old at home. And so we oftentimes got toys and books and things that we could bring home to our son to feel connected, because at the time that Zeke was born, it was during the COVID-19 pandemic. And so based on hospital regulations, our 2-year-old was never allowed to visit our son. And so I think taking the pressure off to say, yes, you have to provide all the care that you can for your child by touching, holding, singing, reading books, anything that you can do to be a parent. But you also can't be here so much that your mental health is struggles. And so I think all of us, if you're a parent, whether you're in the NICU or you're home with your kids, you can't be a good parent if you're not mentally in a great spot. And so I appreciated, again, the familiarity that I felt with the team, that and just feeling like they would tell us, hey, it's time to go take a walk, or hey, we're going to do this procedure with Zeke and we think maybe you should step out. And so in a way that wasn't like you have to leave, but as a way of like, how do you feel like that's going? And so lots of extra communication.
Thank you, Agnes, for bringing that important topic up. As we as healthcare professionals, we know the importance for the infants to have their parents close, but we also understand that it's like skin care is not always a cozy moment that parents are supposed to love and enjoy. We think of it as hard work, and we want to do what we can to support you during that hard work, but it's not like being at home on the couch cuddling with your baby. It's more like hard work than a nice moment.
I would emphasize that, even just the how scary it is. Like, am I going to actually extubate my son? Is something going to happen? And so even nurses coming in and checking and making sure everything is good and reporting like, hey, you can look at his numbers. He's breathing better now. His oxygen is better. And so even empowering me to check, like looking at his vitals to say this is a positive thing. So it is work. I totally agree with that, Victoria.
All right. Well, I think we're at time. So I just want to say thank you again to our speakers and to our moderators for participating. We appreciate, your time, and I want to especially thank Kourtney and Pär-Erik for your willingness to share your personal experiences. And thank you to everyone who attended. I hope that you found it to be valuable, but we're always looking for feedback on how to improve future webinars. So you should see a survey as you close out of the webinar. You can put any feedback there, or please feel free to reach out to us by email or through our website. And you can also follow up, I think, with our speakers, our moderators individually as well, if you have additional questions. And just as a reminder, you can look for this webinar on our website, tinybabycollaborative.org. Great. Thank you all.